Fibrous dysplasia, if you add that it's the monostotic type, that's fine, but you don't have to do that. I'm just looking for fibrous dysplasia, then I'm very, very happy.
I forgot what I said.
Number 3. There's bilateral lesions that are similar. There's linguomandibular bony expansion, and we see what radiographic appearance? Dense, uniform opacity, way up high near the alveolus. It has to be what? Mandibular chloride. There's really not any other possibility with the information. So we try to build cases, and even I know there's so much overlap on all of these.
So she's talking about that little white part right there?
We're going to try to build cases with multiple clues that are going to point you in the best direction. So hopefully that will help. Fibroblastic lesions of the jaws are similar by histology. Clinical features are different. Etiologies are different. So we don't really diagnose them on a biopsy. We do on other basis. What is the most common fibroblastic lesion of the jaws? The cementosseous dysplasias as a group. The most common pattern is periapical cementosseous dysplasia. So if you put that specific pattern, I will take it. But it's really the full group. Okay. Number 5. This was our third one. So first of all, what is the radiographic character of the lesion? Is it lucent, opaque, or mixed?
Mixed.
It's a mixed lesion. It's mixed. It's part lucent, part opaque, and the opacities are uniformly distributed throughout. He's a 36-year-old. It's gradually been expanding. It's well-defined. It's a solitary lesion. That all fits with a benign process. So what did you put at the top of your differential diagnosis? What fits best? Ossifying fibroma fits the best. Everything points to a benign neoplasm that would have a mixed radiographic appearance. So with the age, the best is our ossifying fibroma. What? The gender doesn't help you very much. So even if it has a female predilection, it's not by much, and almost half of them are still in. So that the gender doesn't help you except for things that have a very, 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 very strong.
Oh, you know what? Also, it has an oval lesion right there, which is ossifying fibroma.
This one, lots of history. The affected brother, the chubby cheeks. We see the bilateral, multilocular lucency, posterior mandible. It has to be cherubim. That was the easy one. Yes, we need those two, right? Number 7, what disease of bone is characterized by frenzied remodeling of bone? That's a disease of bone, also known as osteitis fibrosis. No. Osteitis deformans. That's why it's Latin name.
Frenzied remodeling of the bone.
Number 8, this was a little harder one. This is an 8-year-old who has had a slowly enlarging jaw lesion for a couple of years, and you can see there's bony expansion. You can see there's displacement of teeth clinically and radiographically. When we look at the radiographic
but it's
lesion,
slowly.
start with the character. Is it lucent, opaque, or mixed? It is a pure lucency. It is a pure lucency. Is it well-defined or ill-defined?
Ill-defined.
It's kind of well-defined on one side and a little bit less defined on the other because it's not very big. Does it have a corticated border or a non-corticated border? Non-corticated border. So what did you put at the top of your differential diagnosis? Central giant cell tumor. Excellent choice.
Central giant cell
That is
tumor.
what it was, and I will consider all other answers as they come up. Do you see the discoloration in the soft tissue overlying the tumor? The central giant cell granulomas are extremely vascular, and that vascularity can show through. And so that's actually a clue too, even though I don't think we talked about it. It wasn't the other pictures. All right. Vital T no bone expansion, incidental widening, asymptomatic lesion. What is the best diagnosis for this lesion? Idiopathic osteosclerosis.
Yeah.
Nice,
Yeah.
really well-defined densopacity at the apex that fuses with the lamina dura, but you can still see the regions and the PDL, so it's got to be idiopathic osteosclerosis. And what about the crown of the tooth? No decay, no restorations.
I thought, isn't that a restoration right there?
All right, this was a hard one because you could have interpreted the question lots of different ways. So the patient has bone expansion. In the area of bone expansion, there are mobile teeth and these radiographic changes. Did you notice that there is some loss of bone density, but white PDL all the way around two adjacent teeth? So these signs, loose teeth, bony expansion, and white PDL all the way around, you should be suspicious of
Neoplasm?
I'll take osteosarcoma, but malignancy in general.
Oh, malignancy.
It doesn't always point to a specific malignancy, but those are signs of malignancy. If you gave me a specific malignancy, I'm totally happy with that. But I want you to know it is more general for malignancy than it is any specific malignancy. So we can see this with metastatic carcinomas. You can see this with osteosarcoma.
I do remember seeing that.
This with chondrosarcoma.
About there being widened PDL.
So, if I ask for a best diagnosis and you see signs of malignancy, what do you go with? Osteosarcoma or metastatic? It depends on the age of the patient. If the patient is middle-aged or older, in the age group where you get the primary cancers that go to jaws, you go with metastatic every time. If the patient's younger, you go with osteosarcoma because it occurs in a younger age group than we usually see the metastatic lesion. Orange, red, and oxide.
All right.
So is there any one question that nobody got? I was thinking of making one a bonus.
Yeah.
Forensic remodeling. The weird X-ray one? There were two that I thought were hard, but we'll see how you did. All right, ladies and gentlemen, we have a lot to do, so we are going to move right along. And I need to get my Panapto recording done. We need to finish our discussion of abnormalities of teeth, and then the time we have left after that until noon, we're scheduled till noon, is review time. If you cannot stay for the entire review, that is your choice. But I will be here, and it could be very helpful for you. So we'll do the best that we can. We left off, we were still looking at environmental discolorations of teeth. We did not finish our extrinsic stains. As I mentioned in class, I will post a study PowerPoint, but a lot of these stains I do not have good examples. You might actually have better examples in some of your dental hygiene reference texts because you guys polish off stains. So pay close attention to the stains in class, and that might help you better prepare for the final exam. So these are all stains that have a greenish color, and we have two kinds of green stains. We can have green stains because there is exposure to metal, and the metal ions precipitate on the teeth, and metals can be blue. Does anybody know what metals in solution are bluish?
Cobalt.
Cobalt doesn't really go into solution because it's a big metal, but copper. What's another one? Pardon? Silver is not blue in solution. It is actually clear in solution. Nobody take general chemistry or intro to general chemistry? The other one is nickel. Nickel is blue. Nickel and copper are slightly different shades of bluish green, but they have green in them. So sometimes our green stains on teeth are metal stains. We particularly see the green stains from metals In individuals who play a brass instrument that has some copper in the brass, and some of them have some nickel in them too, depending on what they are. If an instrument player has really acidic saliva, they can cause some ion release from their instrument, and it can precipitate on their anterior teeth, and we can get a greenish stain on the teeth in the anterior region. Sometimes we get green from chromogenic bacteria, and our classic green stain that we actually call green stain comes from products from chromogenic bacteria that deposit in nasmus membrane in young people who have never had their teeth cleaned. Do you remember what nasmus membrane is from oral histo and tooth development? Ever heard of nasmus membrane? It's a developmental, it's kind of the developmental residual protein membrane from the enamel organ. And when the teeth erupt, they still have this little coat of protein on them until it is polished off the first time. And stains stick to it better. So our classic green stain we see in young people who have newly erupted teeth that haven't ever been polished, have a lot of plaque that can have some of those bacteria that produce green pigment. And that's our classic green stain. So when we look at these pictures, which one of these is our classic green stain that we call green stain? The bottom one, you can tell that's a young person. And you see the greenish stain in the high plaque. When I was a kid, we had a babysitter that picked us up after school and watched us and my baby brother until my mom got off work. And she had children the same age as us, and there was one of them, she was always chasing around the house with a toothbrush saying, "Terry, go brush that Grandma Moses moss off your teeth," because he had a classic green stain. So if Grandma Moses moss and lots of plaque helps you remember green stain, then think of it that way. But that's our classic green stain. Once nasmus membrane has been removed by coronal polishing, you never get this pattern of staining again. It doesn't stick the same way. So that means that the two other green stains on top, those are metallic green stains that we would expect to see in like a brass player. What about the stain on the right? Is that one green? What color is that one?
Green.
It's brown to black. So the other metallic stain that you should be able to recognize is an iron stain that we often see in children that take chewable vitamins with iron. And the iron can precipitate on the teeth and can cause quite a bit of discoloration. It tends to stick in the pits and grooves the most, but can be on smooth surfaces as well. The good thing about those superficial stains is they are environmental in origin and they do polish off. The iron stains are a little harder to get rid of than some of them. They really stick, don't know why. But so those are our metallic stains. We have some intrinsic stains we want to look at. These are intrinsic stains, but post-eruptive changes associated with tooth non-vitality. So when a tooth dies, sometimes there is some hemorrhage in the pulp, and some of those blood pigments can get incorporated into the dentinal tubules, and we see discoloration through the surface of the tooth. A non-vital tooth usually looks a little darker and a little grayer. Even though they're blood pigments, we aren't going to see red teeth. Just not enough pigment gets in there. So we tend to see a little bit of brownish to grayish discoloration. So it's pretty easy to pick out which of these are the non-vital teeth, don't you think? Which is easier, the one on the left or the one on the right? The one on the left, particularly in comparison to the tooth with the crown next to it. So this patient had trauma to these two central incisors. This one had to be restored with a crown, which matched. These teeth all matched when this crown was placed, but over time, the other non-vital tooth has undergone discoloration, and now it doesn't match anymore. This one's a little more subtle, just a little grayish. So one tooth that's a little off, that's often a sign of non-vitality. A very important intrinsic stain to be able to recognize is a tetracycline stain. Tetracycline is an antibiotic that is also a vital dye, and the antibiotic becomes incorporated into hard tissues during formation and remodeling. Do teeth remodel? No, but bones do. So this is taken up into bones and teeth. Bones at any time you take the antibiotic, teeth only when the teeth are forming, or so they say. It causes grayish discoloration of the teeth, and they will fluoresce yellow. The bones will fluoresce yellow too, but we don't often have an opportunity to see that. Sometimes we get enough discoloration of the bone in the palate that you can see the discoloration through the mucosa, but most of the time we can't see the bony discoloration. Because of the damage to the teeth in terms of appearance, in this country it is contrary to standard of care to give tetracycline antibiotics to a child who is under the age of 7 because it will produce permanent discoloration of the teeth. What do we most often use tetracycline for in this country? We still see people who come from other countries who got this antibiotic as a kid. We still see tetracycline staining of teeth. But what do we use it most for in this country? Nobody knows what we use tetracycline for? It's for infections, but we don't use it for dental infections. It is a common antibiotic to use for severe acne in teenagers, and they often take tetracycline for a couple of years. And when you're taking it every day for a couple of years, it actually can absorb through the dentinal tubules, and we can get some post-eruptive change in color, but it's just a little darkening of the teeth. It is not going to affect the enamel, and we see it more in people who have really translucent enamel, but it can cause a little discoloration, a little darkening of the dentin, but it's not going to look like this. This is definitely discoloration within the enamel. And it tends to be in bands and zones because nobody usually takes tetracycline continuously throughout childhood. But children who have chronic illnesses like cystic fibrosis or something like that, who frequently get infections and have to take antibiotics, may show extensive tetracycline staining of the dentition. And it's not very pretty. And it doesn't protect against decay either. So patients usually want some type of aesthetic treatment, but you should be able to recognize tetracycline staining. Gray to brown bands of discoloration on the teeth since the teeth erupted. So it happens during formation of the teeth. All right. We are going to move into alterations of tooth number. I think you know these really well, so we're going to go fast on these. Hypodontia means there are missing teeth, but not all of the teeth are missing. It could be one missing tooth, it could be multiple missing teeth. So hypodontia just means you have fewer teeth than you should have. We use the term anodontia when we have complete missing dentition, which is really, really rare. Sometimes they use the term partial anodontia, which is kind of stupid. Why don't you just say hypodontia? So I prefer that you say hypodontia rather than partial anodontia. But hypodontia is very common. It's usually just one missing tooth. Complete anodontia, very, very, very rare. Single most common tooth that is missing is a third molar, and those are lucky people because they don't have to have all of their third molars extracted. They only have to have the ones removed that are present. Second most common missing tooth is a mandibular second bicuspid. So here we have a child with primary molars. This is the developing first bicuspid. There is no developing second bicuspid. So here we have anodontia, partial or hypodontia, missing tooth. That's a really common pattern. My ex-husband, his identical twin brother, and their father have this that's bilateral in that exact position. It's a very common tooth to be missing, that mandibular second bicuspid. My father-in-law, in his late 80s, still has one of those baby teeth. he lost the other one in his 50s. You can keep a baby tooth a really long time if you take care of it. Another common one to be missing is maxillary lateral incisors, and that is often bilateral. And the cuspids shift forward, and sometimes we do things to make them look more like lateral incisors. But those are the three most common teeth that are missing in the permanent dentition. There is one hereditary disorder that I want you to know the name of that is associated with multiple missing teeth. That's characteristic of the syndrome. And the teeth that are present are malformed and are pointy little conical teeth. This is called hereditary ectodermal dysplasia. It is a mutation that affects ectodermal structures. Ectodermal structures make skin and hair and other things that have an epithelial component. Do teeth have an epithelial component during formation? Yes. The enamel organ is of epithelial origin, so they have weird enamel and missing teeth. So it's kind of a weird thing. So these individuals have very thin body hair, scanty hair. They don't usually have sweat glands at all. They tend to overheat. They have missing eyebrows or very scanty eyebrows and eyelashes. Don't get beards when they go through puberty. They just don't have enough hair follicles for that. And then they have many missing teeth, and the few that are present are these funny little conical teeth. We make them baby dentures because they just have nothing to work with. Question?
Do you say overheat?
Overheat.
Oh.
They overheat. They can't sweat to cool down, so they have problems with overheating. They can get heat stroke very easily. Good thing you asked. Question?
I don't see this in here. Is this something that we really need to...
It'll be in your study PowerPoint, but it is something I want you to be aware of because it's very distinctive. If you ever saw it in a kid that came through your practice, you would know what it is.
So when they lose these teeth, normal teeth might come in?
Nope.
Or no?
Nope. Affects both dentitions, so they get the funny conical permanent teeth too, and mostly missing permanent teeth as well. So it affects both primary and permanent dentitions. It's one of those little pieces of trivia that shows up on national boards as one of the hereditary causes of missing teeth. So, and because it's so distinctive, it's an easy one. It's an easy 3 point if you've ever heard of it. All right, hyperdontia means supernumerary teeth, extra teeth. Up to about 3% of the general population has that on a public health scale. That's pretty big. So extra teeth are common. And sometimes they don't look normal. They are much more common in the maxillary arch than the lower arch, and the single most common pattern of supernumerary tooth is a mesiodens, and I know you've learned that. That extra little funny small conical tooth at maxillary midline between the central incisors. Sometimes there are two. I've seen 3 together, but it's usually just one. Sometimes they point down and will erupt. Sometimes they point up and are headed north to the nose. They're very interesting, but what's the best term for them? If I show you one on our final exam and ask you the diagnosis, what's the best diagnosis? Supernumerary tooth or mesiodens? Mesiodens. The most specific diagnosis that applies is always the best diagnosis. Other common places we get extra teeth are fourth molars. 1 or all 4 quadrants. So some people get to have their extra wisdom teeth. So they are super wise, I guess. They get 3rd and 4th molars that get to be removed. Sometimes we'll get a small extra molar that's called a paramolar. And sometimes we have a small 3rd molar or 4th molar that's teeny tiny and that we call a distodens. A distodens isn't usually actually supernumerary. It's just an abnormal morphology of a 3rd molar. This was an actual patient that we saw here at the School of Dentistry, and this was the study model that was taken. And it's like, oh my goodness, where did all those teeth come from? So some people can have lots of extra teeth. Frequently, patients with lots of extra teeth have a genetic syndrome, like cleidocranial dysplasia or something like that, that's characterized by multiple supernumerary and impacted teeth. I don't think we've taught you any of those syndromes. They tend to be very rare. But if you have a patient who has lots of supernumerary teeth, you should be aware that that could be due to a syndrome and not just one of those little freaky developmental anomalies. That's an isolated kind of a thing. So, those are my mesiodens. Aren't they cute? I love them. I like to take them out. Actually, they're fun. So you've seen them. So what do we see in this patient? 1, 2, 3, 4 molars. 1, 2, 3 molars. 1, 2, 3, 4 molars. 1, 2, 3, 4 molars. So 3 quadrants have a 4th molar. What do we see in this patient? Extra bicuspids. So extra bicuspids are another fairly common place to have a supernumerary tooth. And this was a patient, actually I saw this patient in the surgery center, and patient has 1, 2, 3, 4 molars. 1, 2, 3, 4 molars. But the ones on the lower in that quadrant were causing problems and had to come out. All right.
I know.
Are these supernumerary teeth?
No.
Little guy.
Over-retained primary teeth with permanent teeth that came into the facial. So you have to think carefully when you have extra teeth. Are they part of the same dentition? Are they all primaries and they're extra teeth? Are they all permanents? Are they extra teeth? Or do we have some retained primaries and then permanents on top of them? So this one is not supernumerary teeth. It's a little misleading. Okay, what about this one? We have a retained primary, and here's a cuspid. I know you're not used to working with mixed dentition. This is cuspid. Permanent lateral, permanent lateral, permanent central, permanent central, permanent lateral. How many permanent incisors are there? 5. So we do have a supernumerary tooth. So you got to count teeth, and you have to know how many there should be. So there are 6 incisors. 1 is a retained primary, which doesn't count, but there are 5 permanent. So that patient has a supernumerary lateral incisor. This is a patient who's got 3 bicuspids. One of them turned completely around, so you have to look carefully at the morphology to decide which one is the normal one and which one is the supernumerary. This patient I love. Cyclops tooth. Has not had an extraction. So this is an anomalous tooth, and there's a missing tooth. We haven't gotten to that one yet. But then down below, cuspid, lateral, central, central, lateral, lateral. You can floss between all of them. They're separate teeth. So here we have supernumerary, and here we have missing. Patients can get crazy things. So that patient has supernumerary teeth and missing teeth. All right. Alterations in tooth size and shape and morphology. Microdontia. Microdontia is relative to the rest of the dentition. Generalized microdontia is hard to diagnose. How do you know if they're smaller than normal or just the size they should be for that person? So I'm not ever going to show you a generalized microdontia. We do see it in Down syndrome patients, but that's about the only time when we really know it's microdontia. And they have short roots too. So usually microdontia is a diagnosis that we use for a single tooth or maybe a couple 3 teeth in a patient whose other teeth are in the range of normal size. Single most common microdont that we see is a peg lateral, where a maxillary lateral incisor is smaller and doesn't have normal morphology. It tapers down toward the incisal edge, and that's why we call it a peg. Lateral looks like a wooden peg. Sometimes it's bilateral, sometimes it's only one tooth. Those are usually pretty easy to fix aesthetically with porcelain veneer or crown. Second most common microdont we see are third molars, those distodents, those very small third molars, which is kind of nice because they might not ever need to be taken out or will be very easy to take out. Macrodontia means larger than normal teeth. Generalized macrodontia does occur It's hard to diagnose. Some people have tooth jaw size discrepancy. Their teeth are too big for their jaws, but who says that their teeth are too big or bigger than normal? That's a hard call to make. So again, we tend to use the term macrodontia, macro for bigger than normal, when it's just one or a few teeth in a patient that are bigger relatively than the rest of the dentition. So I have two examples. The patient on the top picture, what is the macrodont? The mandibular cuspid. It's even bigger than the maxillary cuspid. So definitely that's the macrodont. Does it look hugely anomalous and weird and bizarre? Not really, but it is bigger than it should be. It's pretty subtle. I might not show you one of those. What's wrong with the lower case?
The root.
The root. It has macrodontia involving the root. The root is really, really long. And the first thing you would think is elongation due to incorrect positioning of the x-ray cone. And so is this an artifact? But if you retake it and you know that you're correct with your positioning, then that would be an example of macrodontia. So, but we don't see that very often. Not very often. Alteration in shape. You know most of these. I think you know most of these. I think you've seen these. Have you learned gemination? Okay. So gemination is sometimes called twinning. It is when a tooth bud tries to separate into two teeth but doesn't completely separate. If they completely separated, we would have supernumerary teeth. If they incompletely separate, it is gemination. So it is a larger tooth than normal, usually kind of with a groove that separates the two lobes of the tooth where it was trying to separate. This is gemination in a banana. It tried to separate into two. And they actually do peel apart from each other on the inside of the peeling. So that's a nice conceptual example of gemination. In order to know you have gemination, you have to count the teeth and you have to know how many there should be present. This is a patient, these are orthobands when they used to do the permanent metal ortho retainers. So these are cuspids, and we have lateral, central, central, lateral, but it's bigger than normal and it has that little groove in it where it's trying to divide into two. So that's an example of gemination. If it didn't have the little groove, then you would just think it's macrodontia. But they usually have that little groove, and that's what tells you it's gemination and not macrodontia. All right. What about this patient? Cuspid, lateral, central, bigger central, lateral, cuspid, has the little groove in it, so that makes it gemination rather than macrodontia. So there are clues. Those may be a little hard. This one is radiographic, and you can see a really big wide tooth, two separate root canal chambers, and this patient got huge caries on that groove at the separation line, and so this is the decay. I don't have the clinical photo that goes with that. So sometimes you can see the twinning on radiographs.
So that's the gemination for the central?
This is not this patient. These are different patients. Is that what you're asking?
No, I'm just asking.
These are all gemination. This is gemination.
For central.
For the central. Okay. Fusion can look deceptively similar to gemination, but it is a different process. And again, you got to count teeth or you can't figure it out. So fusion is when two separate tooth germs fuse together. So we're going to have one less tooth when we count teeth, but you're going to have a larger than normal crown, and you're going to have that groove. Here it represents a fusion line instead of a gemination line. So the way you tell gemination apart from fusion is counting the teeth. Occasionally it's bilateral. So this is a kid who has primary cuspid, fusion of central and lateral, and there's our fusion line, fusion of central and lateral, and cuspid. So the fact that there's missing teeth tells us it has to be fusion instead of gemination. There's no history of extraction of teeth. Does that help? Okay.
If they have it as a primary teeth,
do they get it as a secondary?
Good question. If you have fusion or gemination in the primary tooth, it may or may not carry on to the permanent. We always check the radiograph carefully for the developing permanent teeth. Sometimes we can't tell until it erupts. Sometimes we also see it in the permanent dentition, and sometimes we don't. Sometimes we'll get normal permanent teeth. So some kids get lucky and some don't. And this is the radiograph for that child, and you can see the fusion, one root, and the fusion line kind of separating crowns, but cuspid, lateral fused with central, lateral fused with central, cuspid. Does it persist into the permanent teeth?
No.
Yes, it does. Because that's a cuspid. These are the only two incisors, and that's a cuspid. So, yeah, it did persist for that patient. All right, this is very interesting. This is mixed dentition. So this is primary first molar, primary second molar, permanent first molar, fusion of second and third molars. Interesting. And there they are, fused together in a different patient. Cool. So that's fusion. Talon cusp. Yes.
For like those fused molars, is there a problem or can they keep it like that?
We can keep it. One of the problems is we do have increased caries risk on the fusion lines. And so they need to take very good care of those teeth. When we find teeth that have fusion, as soon as they erupt, it's really, really smart to put sealants in to protect those grooves. If we get decay in the grooves along the fusion line, it hits pulp really fast. And sometimes these are very difficult teeth to do root canal therapy on because of the very anomalous root canal morphology. And so as long as we keep them healthy and they're in occlusion, they function okay, there's no reason not to keep them. The ones in the anterior region give us some aesthetic problems. Posterior region, it's not a problem at all. No. Good question.
Dr.
Yes?
Was there a decay on that fusion line there? No.
Nope, not on the clinical picture one, but in the radiograph, absolutely. See it right there? Yep. So decay is a problem. All right, talon cusp. I don't know if you've learned that one. A talon is that extra claw on our birds of prey. And so talon cusp is a prominent pointy extension of the cingulum that we see in maxillary anterior teeth, usually on a lateral incisor, but it could be any of the maxillary anterior teeth. It can be one tooth, it can be multiple teeth, it can be bilateral and symmetric or not, but it's called a talon cusp. And this is a patient who has a talon cusp at one tooth, and this is a patient with talon cusps at two teeth, but a very prominent kind of pointy cingulum. We see those more commonly in individuals who have shovel, digging with a shovel incisor morphology of their incisors, which we see typically in individuals of Asian or Hispanic heritage, American Indians as well. Dens indentate, have you seen that one before? Another name for this one is dens invaginatus, and it's a developmental anomaly. It's almost like the tooth bud was pushed in on itself, and we kind of get a tooth that forms inside the tooth. It can be seen at any tooth. Single most common tooth to be affected are maxillary lateral incisors, and this is a maxillary incisor that has two of them. There's one of them, and you can see this part is exposed to the oral environment through a deep pit, and then we have the enamel layer, and then the dentin layer, and then the pulp. And this one is the pit, and then the enamel, and the dentin is just surrounding dentin. One of the problems with these is that it's easy to get decay deep inside those pits, and the decay can reach the pulp very, very quickly. So when this is identified radiographically, it is best to put a sealant in those deep pits just as soon as the tooth erupts to prevent a future of decay and non-vitality in the teeth. This is a lower tooth that has a very interesting tooth inside the tooth. And it has gotten decay, and it did reach the pulp, and we have a nice periapical dental granuloma. Lovely one there. So some of them are small, some of them are large. We call them dense and dentate. And this is a patient who has unusual pattern of multiple bicuspid teeth with dense and dentate. And this one had to have root canal already, and it affects some maxillary teeth as well. I don't know if you can see it, but it's there a little bit, and there a little bit as well. So sometimes it's posterior teeth, and sometimes it's multiple teeth in the same individual. Enamel pearls, very uncommon. A little knob of enamel on a root surface, usually at a furcation. They become a problem in patients with periodontal disease where there is loss of attachment down to the enamel pearl, and you guys have to clean around these things. So hygienists need to know about them because they give you a lot of grief. As long as we maintain good periodontal health and don't have any attachment loss down to the enamel pearl, they don't cause any problems. But they're kind of cute. We don't see them very much. Toroodontism, have you learned that one? Those are the bull teeth that have a larger than normal pulp chamber at the expense of the root canal space. If the tooth has a furcation in it, it means there's going to be downward displacement of the furcation. This is a bicuspid tooth where if we have a double-rooted tooth, the furcation should be up here. We should split in two roots way up here, and the division is way down at the bottom. So this is all pulp chamber instead of root canal space. This is the root canal space. So that's toroodontism. It can affect one tooth. It can affect the entire dentition. It varies a lot from person to person. It is definitely easier to see in posterior teeth that are normally multi-rooted. We can see it in permanent and primary teeth. So it's just an interesting thing. Don't you like that? Yeah. That's our bull tooth. Hypercementosis. We saw when we were talking about complications in Paget disease of bone. It is usually an acquired anomaly in a tooth that's got stresses on it, and we get overproduction of cementum. So we get secondary cementum. Just like you can get secondary dentin on the inside of a tooth, you can get secondary cementum on the outside, and it just makes a really thick layer of cementum. The periodontal ligament space is on the outside of this funny bulky root, and usually normal PDL and lamina dura. Those can be very challenging teeth to extract. So we need to keep them healthy so we can leave them there. Dilaceration means we have an abnormal curvature on a tooth. Growth of the root is what makes teeth erupt. Sometimes if we have infection or something like that with primary teeth, it causes displacement of the tooth bud of the permanent tooth. And so in order for that, after the primary tooth is treated, in order for the permanent tooth to erupt, it has to take a circuitous route to get back to where it should be. And that's why we get those funny dilacerated roots. We like to keep those teeth healthy as well because they are very hard to do root canal treatment on, and they are very hard to extract. And I just saw one this week for a patient pre-doc clinic, and the tooth needs to be extracted, and it's like, refer to grad clinic. That is not a general dentistry extraction. It's going to break. It's going to be a problem. So, dilacerated root. Do you want to take a break and come back and talk about our two developmental things? All right, let's take a break. A quick break, and then we'll finish. Do quick and dirty two genetic diseases.
Oh, thank you.
You're welcome.
Almost two? Sounds just fun.
I don't know. I don't even really what it
What did it look like? I don't know.
I looked the Muffy. Wait, for only the first exam, right?
That was hyperthyroidism of bone. I changed it to paget of bone. Disease of bone.
Those are different diseases. Which was the question?
The question number one was the
Non-expansive, that pageant disease of bone would be incorrect.
get 0 or
Changed your mind. So if you change an answer and you put something that's closely related, and so it's along the spectrum, and then I can see your experience off, that's when you might give it a partial credit. So let's say you put periapical cementalosis, which crossed it out and just put the word cementalosis. I was looking for the more specific. I know you're thinking about like. Wait, so what was it? But if you change it to something completely different, that's why it's oxidized deformity. It produces deformity of the bone. Did you get my email? Your last question I didn't answer to this morning. I went to bed after the one meeting, and then this morning I thought I was going to send it to you as soon as I got to the office. And I remembered I had to go down to Clinical Care Dentistry, and then Dr. Lyman said, "Oh, you didn't finish one of your reports on tonight." I didn't know my reports. Oh, you didn't. So I saved my report. And I ran it. You're asking me questions. That means your mind is thinking about the right things. You're getting there. Central giant cell granuloma.
That's why I was.
All right, first case. But remember that central giant cell granuloma does not have a strong site selection. That's not anywhere in the jaw.
I just picked it on the ground, so.
So that example just happened to be in that location. Oh, the fibrous dysplasia case. The ground glass bone. It was a ground glass bone. So you are hanging your answer on a location, whereas that's on down the line. So your answer first and foremost has to match the radiographic appearance of the lesion. So that's why I always ask you first, is it recent opaque mix or ground glass? Because that is the most important thing to match.
That was a good image of it. I
Yes,
understood it.
didn't make
Yeah.
sense. Yeah.
It was her visuals, and then the other one, the blue one, it was nice. Thank you.
This time next week, we're gonna be done.
What?
This time next week,
I know.
it'll all be done.
Yeah. It won't be
So
for me.
nice. Not for you?
No.
What do you have? I mean,
We have a meeting, a faculty meeting that goes most of Friday, working hours. I think we finish at 1 p.m. And then I have to score everything since I have a late final. I have to make grades. And technically grades are not due until Tuesday at 4 p.m. But Tuesday I'm having surgery.
oh my gosh.
I have to finish my grades on Monday.
Yeah.
And Dr. Grandi can't help me because she leaves on Friday morning of next week to go to our national oral path meeting. I don't even get to go this year. And she won't be back until Wednesday night after grades are due. So I have to do grades by myself and have to be done by the end of the day Monday. So we are going to score the write-in answers.
Yeah.
We're going to review the scoring on Thursday afternoon before she leaves town.
And so that you can just do the other scoring.
And then I have to get everything imported, make sure I'm happy with all of the written questions, but all the clinicals where you do type in and there's any possibility of more than one answer being accepted, we have to do that together on Thursday afternoon before she leaves town.
Wow.
And then I have to do
It's like rushed.
yeah, it kind of is.
My goodness.
And who only knows when I'm going to get today's quiz graded, and I'd like to get it graded today, but I've got to finish that part. I've got to do my final exam questions. I have to.
Is it okay if we go out the dental school where it says like dental school
Yes,
entrance?
but y'all need to do it now, and you need to do it quick.
Okay.
Comes out of your review time.
For what?
All right, ladies and gentlemen, I understand that your officers want to take an end of the first year photograph, class photograph out on the lawn, and we're going to do that now at the end of the break. Right now, out, because we do not, some people have to leave after class and can't stay for the whole review, so we're going to do the photo now. Yes?
Follow me.
I'll stay here and tell them go out. Out by the what, statue?
Like where it says, like just the dental.
Oh, okay. What do you do? Middle school.
Sorry.
Very funny. I love it. You guys have an awesome day.
Yes.
Oh. I did so much better this time. Because the graph thingy.
See? It helps how you think about it.
It helped me so much.
And you know what? A lot of what helped you about it was actually creating it. You learn so much by creating it instead of thinking about
It
it.
helped me so much. Thank you.
Good. Go out and take a picture.
Oh.
Move it. They will miss you if you're not there. So how did quiz go today compared to the one on cysts and tumors?
I'm mad I didn't do idiopathic when I knew it was idiopathic and I did convincing instead.
So what happened to that last quiz? Because you guys all surprised me. Did you guys all go out and get your hair and nails done the night before or something for the big program, the pinning? Because
Yeah, I think, well, with me at least, there was just so much graduation.
I know there's so much
stuff
going on. I figured it had to be all the graduation things
And
going
then
on.
there was
'Cause
3 subjects to
consistent-
learn, so it was just a lot.
3 consistent low scores that you guys that really surprised me because you guys have been doing pretty good. Yeah. It was like,
I know,
Yeah,
it's like
I
from
like
grade.
yeah. So I hope today went a lot better. The bony thing, you know, the bony thing should be easy for you guys now because you're used to looking at radiographs, and at least you can see the lesions. Whereas they're having trouble seeing their users because everything looks the same still to them. What's normal? I don't know what's normal. What's pathologic? I don't know what's pathologic. So at least you have the edge on that. So hopefully the final, the bony lesions will go better for you. Do you have other final exams or not much?
Just one.
Just one.
Tuesday, yeah.
Oh, so that's not bad.
Yeah.
That's not bad. You have lots of prep time. This is good. Very, very good. Have you guys been able to get together with Trent?
We're planning for Monday at 5.
Oh, good, good.
So that gives us a weekend to find where we're leaving for.
Good, good. Excellent. That's excellent.
You can't do that.
I looked at graduation for the things that you put on your workbooks. I love all the art and sayings and everything else. That was good. Very good.
I just wrote a tube with wings. That's cute.
That's my fave. I can't.
That's what happens when you hang out with Katie.
Wait, no. My brother saw that. And he was like, he didn't know that we were friends. And
No. It's such a cute photo. I think those are the ones that Barbara took now. Yeah.
and he was like, oh my gosh, what if I
Me
did something for him?
No, they look okay.
I was like,
I love Cynthia's hair.
oh.
I'm gonna go back and Are you gonna go back too?
I told you. I should have kept that.
Thank you. That was fun. I'm glad you did it. Never picks up her again. All right, are we ready?
Yes.
Okay. We have 2 genetic diseases that I want you to know a little bit about. There's a third one that's in your notes that we're not going to cover that's really rare. So it's just the 2 main ones. And these are developmental genetic alterations in the structure of teeth. The first one, oh, come on. It's not. There, it's moving now. The first one is called amelogenesis imperfecta. What does the amelogenesis word mean? Enamel formation. So this is a genetic disease that produces imperfect or altered formation of enamel. And incidence varies from 1 in 700 to 1 in 14,000 people, depending what study. Most of the studies are old. So it's not common, but it's distinctive enough. You should have a suspicion if a patient has a genetic disease that has produced abnormal enamel. These are different mutations. There are multiple genes that are involved in the formation of enamel. You don't have to learn all of those genes. But it can be transmitted in different ways in different families. So in some families, it'll be a Mendelian autosomal dominant disorder. Dominant disorders are going to be seen in every generation. One parent will be affected, and usually multiple siblings will have it as well. So those are pretty obvious. The recessive ones, you have to inherit mutated genes from both parents in order to get it, so those are exceptionally rare. And often, no known family history because nobody that was carrying the recessive gene married another person that had it, so they didn't even know it ran in their family. The other type is X-linked, which means the defective gene is on an X chromosome. These are not usually seen in women because the normal X covers for it, but men only have one X, and so they're affected. So it'll affect all the males in the family. So those would be the second most common type. Do you have to know about all the different forms? Not really. It's just an awareness helps you understand why sometimes it's seen in every generation of the family and other times it's not. This is a disease that affects primary teeth and permanent teeth, and similarly in both dentitions. There are different, depending on which gene is mutated, it can be a hypoplastic change, a hypocalcified change, or a hypomaturation change. Do you have to know the type? No. But because there are different types, there's some variability in the clinical presentation. And so you can just expect there to be changes. Hypoplastic type is actually the most common type. So they have thinner than normal enamel that tends to have pits and grooves in it. So the pits and grooves is very characteristic. The hypocalcified type is more normal in thickness, but it doesn't mineralize properly. And so it's chalky and may chip off. The hypomaturation type, I can't figure out. It's bizarre. So here we have a girl, and you can see some discoloration, and you can see some pits and grooves that affect all of her teeth, and they erupted that way, and the baby teeth were that way. So you put that all together, and that fits with a melogenesis imperfecta. If we have good oral environment, we do not have unusual problems with decay. If we don't have a good oral environment, we get decay, it'll go through the thin enamel pretty fast, but this is not inherently more prone to decay. So discoloration, some chalkiness, and those pits and grooves, that's a good example of a melogenesis imperfecta. All the teeth, both primary and permanent dentitions. And this one you can see where it's chipped off, but it has chalkiness and some grooves, and it's super, super thin. So that fits with a melogenesis imperfecta. And the patient down below, there's just no enamel. Just almost no enamel at all. So variable appearances, variable severity sometimes, but the most typical thing is the thin enamel and the pits and the grooves. What might you get confused with this? No. Fluorosis if it's chalky, but fluorosis we don't usually see uniformly in both permanent and primary dentitions. It's usually one or the other. Sometimes it's both. Fluorosis is more common. Often not a family history either.
Oh, I just had a question on this. Is it always going to be all the teeth?
It's always all the teeth, and that's very important. It's always all the teeth. The thing that you're most likely to get confused with the melogenesis imperfecta is environmental hypoplasia. But usually that's only some of the teeth and just part of the tooth that's forming at the same time that was under the environmental influence, not the full crown of every tooth in both primary and permanent dentitions. So if you think about extent and distribution, you should be able to tell the genetic ones apart from the environmental hypoplasias, okay? That will help you a lot. Sometimes we get radiographs, and even on a radiograph, you can see just very, very thin enamel. Very, very generalized thin enamel. That would not be environmental. That would be genetic. All right. There are lots of dentin disorders. There's only really a couple of genes that have been identified that are associated with those disorders, and so we have a little bit more uniformity, I think, in the dentin disorders. The only one that's common enough for you to know about is dentinogenesis imperfecta, which means we have a genetic syndrome that produces abnormal dentin. Do you see dentin on the surface? You're not supposed to, but we do see changes that are visible through the enamel because dentinogenesis imperfecta produces altered color of the dentin. It gives it a bluish to brown color, so it gives it, as that shines kind of through the enamel, it makes the teeth look opalescent, kind of opalescent to amber in color. So we can see changes clinically. Most of these are transmitted as dominant disorders, and so it runs in the family in every generation. There are different types, and so you will have, as we're learning more about the genetics of these disorders, we're looking at changing the names and dividing them up differently, but an official proclamation to change the names hasn't been accepted. And so I'm going to have you learn the traditional naming system. That's what you're most likely to see on your national boards. And that's dentinogenesis imperfecta type 1, 2, and 3. And clinically, they pretty much look the same. Radiographically, they're different, but clinically, they're the same. We see bell-shaped teeth, which means there is a constriction at the cervical cemento-enamel junction area. So the crown is bigger than the root, so they kind of constrict as they come in. So they have bell-shaped crowns, and then we have that amber-colored dentin that shows through the enamel as opalescent teeth. Because the dentin is not normal, the enamel doesn't attach to it properly, and we do have problems with the enamel chipping off. Even though the enamel itself is normal and not weak, it doesn't stick to the dentin properly. So a lot of times we do have exposed dentin, and you can see the exposed dentin is quite amber in color. And that's very characteristic of dentinogenesis imperfecta. And even the roots can fracture because they're short. So you see the amber color? And you see the where the enamel has broken off the teeth because it didn't stick properly. Yeah. Here we have a radiograph that is characteristic for dentinogenesis imperfecta type 1 and 2. Type 2 is classic dentinogenesis imperfecta, but on both of these you can see the bell-shaped crown where the crown of the tooth is normal, but then it constricts, and we have a small narrow root. And you'll notice also what is different about these teeth radiographically, besides the narrow short roots and the bell-shaped crowns. No pulp chambers. No pulp chambers. So that's very, very characteristic of dentinogenesis imperfecta for type 1 and type 2. For type 1, which is not the most common type, it is caused by a mutation in a collagen gene, and that collagen is necessary to make dentin as well as bones. And so these are individuals who have abnormal bones and dentin. And so they have osteogenesis imperfecta, which is associated with brittle bones with pathologic fractures. So you know that you're working with dentinogenesis imperfecta type 1 when we see the characteristic features of dentinogenesis imperfecta in a patient with abnormal bones and history of lots of pathologic bone fractures. That would be your clue, the pathologic bone fractures. Okay? Our dentinogenesis imperfecta type 2 is our classic dentinogenesis imperfecta, our most common pattern of dentinogenesis imperfecta. They have normal skeleton. The mutation does not affect the bones. It only affects the dentin. So they have the classic appearance of the teeth. The amber dentin, the opalescent appearance, the enamel that chips off, the bell-shaped crowns, the short roots, and the no pulp chambers. So that's classic for dentinogenesis imperfecta type 2. Dentinogenesis imperfecta type 3 is very uncommon, but very distinctive. It occurs in a special population that we see in the southeast, where there's intermarriage of 3 different races. There's Native American Indian, Hispanic, Caucasian, and sometimes more than that. But the genetic mutation just runs in that population where there's a lot of inbreeding, where cousins marry cousins, and so that kind of magnifies abnormalities. Clinically, it looks like dentinogenesis imperfecta, but when you take radiographs, it looks exactly opposite of our typical dentinogenesis imperfecta. We have huge pulp chambers instead of missing pulp chambers, so they look like shell teeth. So the shape of the teeth and the color of the teeth looks just like regular dentinogenesis imperfecta, but radiographically we have huge pulp chambers and almost no dentin at all. So you would recognize it because of the radiographs, okay? Might not show you one of those. What's most important for you to recognize is our classic type 2 dentinogenesis imperfecta, okay? And the dentin dysplasia that's in your handout, the 2 types of dentin dysplasia that's very, very rare, we are not going to cover. And you are not responsible for those in any way. The only genetic diseases that produce abnormal teeth are the amelogenesis imperfecta and the dentinogenesis imperfecta. So we good with that? All right. And it's review time. I have 2 reviews that I have put together. I have one on jaw lesions, and I have one on soft tissue things. Which would you like to do first? All right. I had a feeling we would go for soft tissue, which works for me. And do you want me to record it?
Yes.
Just saying, I'm asking.
No, always.
Okay. Give me just a second to hit the start button for the recording. All right, here we go. We're going to go kind of fast. I thought about turning on the mic and having you pass the mic and asking you questions.
Okay.
Could you deal with that?
We can all be embarrassed together. Why not?
My experience has been that you actually are all thinking alike, and getting it out and discussing what you're thinking is the best way to recorrect.
And if you get it wrong, you won't remember it.
Okay, so what I have done is I have put together a geographic tour through the mouth, and we're going to look at things in different locations, just organized by location because it was just fun to do it that way. It doesn't cover everything, but we have a lot of things to look at, and we're going to try to go through them quickly.
Do we have access to any handout or anything to go with?
No.
Okay,
No.
I thought I saw something.
All right, so we're going to start with things on the gingiva. This is my most normal gingiva. It should be nice, light pink, stippled, good form. Okay. These are both patients who do not have good form. The story for the patient on the left, which is our first patient, is this is a patient who hasn't been to the dentist for a few years, who's been homeless for a while, finally went into one of those free clinics because he had this mass on his gum tissue, and it's been there. It grew really rapidly at first, and then it kind of stopped growing. It kind of stabilized, but it's been there about 9 months, and it bleeds if he touches it. He doesn't like it. So, what would you put on your differential diagnosis for that one?
I would. Okay, I would say peripheral giant cell granuloma.
I like that idea. Pass the mic. What else would you put on the differential for this?
Hillary.
All of you should be thinking fast because we're going to move that. So, peripheral giant cell granuloma. What else? Say it.
Put it in there. Yeah.
Say it. No. Speak up. When you say it, you learn it. Awesome job. Pass the mic. There's one more thing that this could be that's the 3 Ps. What's the third thing?
Irritation fibroma?
No. Irritation fibroma almost never occurs on gingiva. So the 3 Ps are pyogenic granuloma, peripheral giant cell granuloma, and peripheral ossifying fibroma. Can you tell them apart clinically?
No.
Not for certain, and that's why we always put the same 3 things. But there are some slight differences. If they're extensively ulcerated and red and bleed easily, it's more likely to be pyogenic granuloma, which is the most common one. If it tends to be more purple, it tends to be peripheral giant cell granuloma, which is quite a bit less common. And if it's more normal in color, it tends to be peripheral ossifying fibroma. But literally, they can be just alike, and so that's why we always do the 3 Ps. And the types of questions we'll ask on the final exam, unless we give you histology, any of the 3 Ps are going to be fine, and we might ask for a differential. We are going to avoid asking for all 3 because that gives you more opportunities for errors, but don't be surprised if we ask for 2, and you have to have 2 of the 3 there. So you should know what the 3 Ps are and be able to reproduce 2 of the 3. So that one ended up being peripheral giant cell granuloma. Does it look a little more purplish?
Yes.
So the one on the right is a female in her 20s who cut her gum tissue flossing, and then this mass appeared and grew rapidly, and it's been there for about 4 months. So what does that fit with? Anybody? Irritation fibroma, almost never on the gingiva.
No.
It will never be a correct answer for a gingival lesion in this course. It's going to be the 3 Ps again. Yeah. So what's the most likely? Pyogenic granuloma. So somebody commented to me that pyogenic granuloma we see in pregnant women. They are at increased risk because of the hormonal responses to the plaque. But we see pyogenic granuloma in men, women, non-pregnant women. Anybody can get pyogenic granuloma. Please do not think it is restricted to pregnant women. All right, we'll move on. That was pyogenic granuloma. You get to keep the mic. Patient on the left. Patient on the left has gingiva that bleeds spontaneously, very, very painful. Sometimes the patient notices a blister appears and then ruptures quickly, and it's very, very painful. This has been going on for months. Question for the person with mic. I thought you passed the mic.
Oh, I thought you said she could keep them.
No, I thought you could keep the mic. What is the clinical descriptive term we use for this condition? Say it. Say it.
Is it desquamative gingivitis?
Yes, it is. Pass the mic. What is on our differential diagnosis for a patient who presents clinically with desquamative gingivitis?
Wow.
This is just creepy. Okay.
Yes. Ask a friend. Ask a neighbor.
Erosive lichen.
Pemphigus vulgaris.
Pemphigus vulgaris. That's one of the lesser common ones. Pass the mic. What's another one? Mucous membrane pemphigoid. That's one of the more common ones. And what else? One more that typically presents, would be something we would see as desquamative gingivitis. Erosive lichen planus. In a patient who has history of blistering, is it going to be erosive lichen planus? No.
No.
No. No, that doesn't count. I didn't have that. You get to hang on to that mic. If we actually tell you that the patient has observed blisters, your differential diagnosis should be mucous membrane pemphigoid or pemphigus vulgaris. If they're not aware of that and we just see the presentation and there's no story about the blisters, no positive Nikolsky sign, then we absolutely would include erosive lichen planus with the patient. Many patients who have erosive lichen planus producing gingival lesions that look like desquamative gingivitis also have other areas of classic lichen planus, but sometimes they don't. This patient was biopsied and did have mucous membrane pemphigoid. Patient on the right should be familiar to you. So red, kind of slick, tight looking gingiva, but it's just in the anterior segment and it started when the patient got a new lipstick. What does that fit with?
Contact stomatitis.
Contact stomatitis. But don't they kind of look a lot alike? So the story can make a difference. Always correlate your history with your clinical presentation. Alrighty, patient on the left has a funny little lesion right down here. It's dark in the background and then has two little firm lumps on top, and it is on the movable mucosa. What is the most likely diagnosis for the dark spot underneath? What do you think?
Is it the neuroma one?
Is a neuroma a gray spot? What produces gray?
Is it amalgam tattoo?
Yes, it's amalgam tattoo. Why does it have two little lumps on top?
Because they're allergic.
Because there's scar. It's a different patient. These are different patients. The little lumps are scar tissue. There was a traumatic incident where the amalgam was introduced into the tissue. So it's not unusual to have some scarring there. So it's like little tiny fibromas on top of the amalgam tattoo. All right, past Mike. So that was a little lump below the gingiva. This is a little lump above the gingiva. And this is a patient who has history of trauma. A kid traumatized the teeth. They were a little loose. The dentist stabilized the teeth with ortho wire, brings the patient back in a few weeks, see how things are doing. And at the follow-up, we see this lovely little swelling above one of the teeth that was traumatized.
Irritation fibrosis.
Do irritation fibromas appear in 6 weeks? What color is this?
Traumatic ulceration.
No? What color is this?
Lipoma.
It's yellow. Does a lipoma appear in 6 weeks? No. Associated with a tooth that's traumatized. So the trauma has probably done what to the tooth? Devitalized it. So then what's the diagnosis for the yellow swelling that's on above the tooth? That one you should know. The yellow swelling above the tooth is called? Almost. I hear everybody saying it except the person with the mic.
Dental abscess?
The tooth is abscessed. The swelling itself on the gingiva is called, when it tracks, it's called a, everybody say it, parulus. That's a parulus. So the diagnosis for the tooth is dental abscess. The diagnosis for that little swelling where it's tracking is a parulus. Yeah, that was a hard one. Not really. All right, you ready to move on? Oh, great story. Patient on the left. Perfect. This patient went to the hygienist and had his teeth cleaned. And the next day, developed blisters on his gum tissue in 2 spots, very, very painful, and comes back to the dentist about 2-3 days later and says, man, my gums are still really hurting since I had my teeth cleaned by your hygienist. What have you done to me? So do you see the 2 areas of lesions? All right, what do you think is the diagnosis?
Herpetic.
We're off to a good start. What's the thing you have to think about with herpes? Is it primary or secondary? Every time you're dealing with herpes, or you think it might be herpes, you have to think, is it primary or secondary? Is it the first infection or is it recurrence? Yes, so then what's the diagnostic term?
Recurrent herpetic intraoral.
We're creating new terminology here.
Recurrent intraoral. Recurrent intraoral herpes.
Yes, right there. Recurrent intraoral herpes. Notice how each of those is small enough to cover with a coin. Sometimes it's just 1 spot, sometimes it's 2, but I don't think I've ever seen it more than 2 spots. but it is often triggered by a recent dental hygiene appointment. And I did a path consult just 2 weeks ago with a patient who had that. Had his teeth cleaned by a dental student, came back in. Oh yeah, blisters the next day, hurt like heck. All right, recurrent intraoral herpes. Is the patient on the right suffering from recurrent intraoral herpes?
No.
No. Why? They both get a red halo. It's on movable mucosa. And recurrent intraoral herpes is always on attached gingiva or hard palate. It's always on mucosa bound to bone. Except in a severely immunosuppressed person, doesn't count. I'll never test you on that. So this patient says, I get these every now and then. They appear rapidly. They kind of tingle and burn for a few hours first, and then I get this sore that appears, and they last about a week, but they really, really hurt. What's the diagnosis?
Recurrent aphthous stomatitis minor?
Yes, recurrent aphthous stomatitis minor. Does that require professional treatment? A lot of times, no. If they have infrequent recurrences, but if they're getting frequent recurrences, yes. And we prefer topical steroids, professional treatment by prescription from the dentist. Moving right along. Patient on the left has bilateral similar jaw changes, and when you knock on it, it's rock hard. What's the diagnosis? Buccal exostosis. Do you think that's helping this patient brush and floss well?
No.
No. Might be a good idea to remove that. All right. There we go. Does the patient on the right have buccal exostoses? No. Wrong location. This is interdental papilla. Exostoses are not in the interdental papilla. They're going to be under attached gingiva. So this patient on the right is an adult and has a history of a mass that grew fairly rapidly to begin with, and then it kind of slowed down. It's not growing much anymore, and it's been there about a year. It sometimes bleeds when she flosses, sometimes it doesn't. It just kind of sits there, but it's ugly, and she says, can we get rid of it? So, what's your best diagnosis?
Well, I want to say pyogenic granulomas, but
what?
But it's really pink.
But it's really pink, so then you would move to what?
Irritation fibroma.
Irritation fibroma is almost never on the gum tissue, and we will never accept that as a correct answer for a lesion on the gum tissue.
Peripheral ossifying fibroma.
Peripheral ossifying fibroma. If we asked you, if we showed one that's mostly pink like this, and we ask you best diagnosis, we will still accept any of the 3 Ps, even if it's just pink. But just plain pink does fit best with peripheral ossifying fibroma. What grows faster? Malignant neoplasm, benign neoplasm, or these reactive gingival lesions? Reactive. The reactive gingival lesions. But then they stop growing, they stabilize. They don't keep growing indefinitely. Neoplasms keep growing. Keep growing. Benign ones more slowly, malignant ones more rapidly, but still not as fast as these reactive lesions up front. Kind of interesting. Whoa. Who's got the mic? All right. So this patient is a smoker. Do you believe me? I could show this picture for a nice tobacco stain. This patient is a heavy smoker, been smoking for decades. He is a male in his late 50s, and his chief complaint is, I have this growth on my gums, and now my teeth are loose next to the growth. What would you put on your differential diagnosis for this?
Super ulceration, so
what do you think this might be?
it's in the mandibular vestibule.
No, it's not down to the vestibule. It's really kind of attached gingiva, movable mucosa area. It doesn't go all the way down to the vestibule. It's over the root-bearing part of the teeth. No ideas what this might be?
Is it one of the ones we had in this lecture?
I'm just asking you what you think it is.
It's a growth.
Is it one of the 3 Ps? Yes or no? No, then you can pass the mic. Why is it not one of the 3 Ps? Because it's not on the marginal gingiva. Those are all the way up at the edge of the gingiva. This is away from the edge of the gingiva, so it can't be one of the 3 Ps. So that's one of the most important things to think about. How often do the 3 Ps cause tooth mobility?
Rarely.
0. May displace teeth, but they remain solid. Just moves them a little bit. But anytime we have tooth mobility, what should we be concerned about? Cancer. So we have a lesion associated with tooth mobility. What's a good choice? Smokeless tobacco keratosis is not a cancer. We just said this is suspicious for cancer.
Squamous cell carcinoma.
Daniel, what cancer might this be? We just decided this is suspicious for cancer. What cancer might this be?
Yeah, squamous cell
One more word.
carcinoma.
Yeah, squamous cell carcinoma, because that's the most common cancer we see in the mouth. And smoking is the most common risk factor. Pass the mic. That was a squamous cell carcinoma. But the big clue was the loose teeth. And that it's not one of our reactive lesions because it's not in the right place. Okay. So the patient on the right has a gingival mass that has been growing fairly rapidly for over a year, continues to grow. It seems to be growing faster the longer it's there, and it displaced some teeth at first, but now one of the teeth is a little bit loose. What do you think this one might be? This is like, what is that? Who wants to be a millionaire? And you ask a friend and you get your helpline. Nobody knows what this one might be? What do you think this might be?
Does it start with an O?
Does it start with an O?
Or a V?
A V?
No.
No.
Well, I think you should look at the lesion before you think about the O and the V.
Maybe it's
not rolled.
So what color is it?
It's dark.
You're not looking at the lesion. You're looking at your neighbor's notes. Look at the lesion. What color is it?
It's like black.
A dark deep red, purpley.
I see no purple.
It's like a
It's
Okay,
a
red.
dark red to black or brown.
Okay.
It's red, black, brown, not red, blue, purple. So what fits with that? That could be a rapidly growing mass. Tell her.
It's melanotic macule.
Is a melanotic macular mass. It's a flat spot and it's totally benign. We've got a rapidly growing mass that's now making loose teeth, and it's growing faster the longer it's there. That fits with cancer. What cancer is this color?
Is there any other history of the patient that we can know about?
No. You have more than enough history to get this. Everybody's figured it out except for the people I asked. That's because you're not on the hot seat. So what is it? Rest class.
Malignant melanoma.
It's malignant melanoma.
Oh my God.
The color. The only cancer that's dark like that is melanoma. So you were on the right track with the melanotics. You just picked something totally benign, and this is malignant. Okay. So trust your gut about that color, but then pick the right category.
We'll never have a squamous cell carcinoma.
Will you ever have a squamous cell carcinoma that's brown to black? No. They're red to white.
Got it.
All right. More gingiva. This patient complains of burning pain on the gingiva. It is worse when she eats spicy foods. She's a middle-aged female. She has similar lesions to this bilaterally on the buccal mucosa. What is the single best diagnosis? Everybody stay quiet except for the person with the mic. First of all, how would you describe the lesion?
There's some white stripe.
White striations.
Ah, you said the key words. What goes with white striations?
Lichen planus.
Absolutely. You're done. Pass the mic. This is lichen planus. See how easy that was when you can figure out the clinical pattern? It takes you right to the diagnosis. All right, lichen planus. That's reticular lichen planus. Does the patient on the right have lichen planus? No. We have no striae. So this is a patient who presents with a solitary lesion, and there are no local mechanical factors that were associated with this lesion. I think this lesion might be familiar to you all. So how would you describe it?
It's a leukoplakia?
Yeah, it's a leukoplakia. It's a white patch. Notice it's kind of a regular surface, kind of leathery, and there are no mechanical factors, so that makes it a leukoplakia. So it's a nice white patch. It doesn't wipe off. So what's the most likely diagnosis?
Benign keratosis.
Benign keratosis. What's another good diagnostic possibility? Pass the mic. If it's not benign keratosis, what is it likely to be? If it's a leukoplakia, a white patch won't wipe off, can't be characterized as any other disease, no local mechanical factors. It's either benign keratosis, hyperkeratosis, 80% of them are. What's the next most common diagnosis? Nobody remembers? Epithelial dysplasia, which is premalignant. How likely is this thin white patch to be a squamous cell carcinoma? Extremely low. There is no mass there. So don't tell me that it's a squamous cell carcinoma. If you think it might be an early malignancy, you can say early invasive squamous cell carcinoma. You would get credit for that because that has no clinical mass effects, but it has microscopic invasion when it's biopsied. But if you say outright squamous cell carcinoma, you will not get credit because this doesn't look like a cancer. It has no signs of malignancy at this point. All right. That one was benign keratosis. We're moving on to the palate. Patient on the left has had this lesion in the palate for a while, probably a few years. He doesn't really remember because he doesn't really care about it because it doesn't hurt. Verruca what? Verruca vulgaris. Pass the mic back to the other side because you got away easy. So, nope, the other side. Back, back, back. All right. What other answer will I accept for anything that looks like a verruca vulgaris?
Squamous papilloma.
Absolutely. So, squamous papilloma or verruca vulgaris. You redeemed yourself. You're good.
Verruca vulgaris.
All right. So, that one was a squamous papilloma. But it's the same to me. You can use either of those as a diagnosis. Does a patient on the right have a verruca vulgaris?
No.
No. What do you think the lesion is on the right? It might be a torus. It's like 99.999% sure it's a palatal torus. What would cinch the diagnosis? If you touch it and it's hard. But you don't have to do that to know because nothing else occurs in this location and looks like that. So, yes, it's absolutely a palatal torus. Good job. We move on. Oh, the patient on the left wears a denture. It's an old denture. It wobbles. It loses suction. She leaves it in day and night, night and day, but wants a new one because it's really awful. So, what is the best diagnosis for what you see in the vault of the hard palate?
Papillary hyperplasia.
One more word at the beginning.
Inflammatory papillary hyperplasia.
Very, very good. Excellent. So, I left the word off, and I ran out of room. But it is inflammatory papillary hyperplasia. How do we treat that?
Nice denture?
Take the denture.
Oh, you cut it off.
So sometimes inflammatory papillary hyperplasia gets secondary candidiasis, and then it's really, really red, and we do want to treat the candidiasis with nystatin. That gets rid of the candidiasis, does absolutely nothing for the inflammatory papillary hyperplasia. So how do you treat the inflammatory papillary hyperplasia? Do you make a new denture that fits? Will that get rid of it? No. You have to remove it surgically, get it back to a nice normal contour, and then make the patient a new denture. Do you know what they taught us when I was in dental school? Treatment of choice to remove those was a slow-speed acrylic burr. Numb it up, whiz it out. Oh, barbaric. So I think electrosurge loop is much kinder, but anyway. No, that's seriously what they taught us. Laser is not a good one. It takes forever to laser them off. Forever. All right, where's the mic? All right, does the patient on the right have inflammatory papillary hyperplasia? No. What does the patient have? Do I even need to give you a history? No. What is it?
Nicotine stomatitis.
Is nicotine stomatitis. All right, everybody in the class. Is nicotine stomatitis a potentially malignant disorder?
No.
No. It has essentially the same risk for malignancy as clinically normal tissue because it's associated with the heat from the smoking, usually a pipe, and not carcinogen exposure. So, not a potentially malignant disorder. And it's a beautiful nicotine stomatitis. They still should stop smoking. But. All right, pass the mic. Who's got the mic? Very good. The patient on the left has no symptoms, was unaware of this lesion. It was found on examination. This is a really close-up picture. This is the posterior maxilla. This is that pterygomandibular raphe. This is buccal mucosa. This is soft palate. Patient wears a denture, and this is where the edge of the denture kind of digs in. So you know where we are. How would you what clinical pattern of lesion do you see?
Would be
Red, white, green, blue, patch, ulcer, blister, nodule. What do we see?
speckled leukoplakia.
I think I would call that a speckled leukoplakia. Do you think there are local mechanical factors that are responsible for that? What's going to rub back there? Think about it. Nothing. Nothing. It's past the denture, so it's not mechanical. Does it look like any specific disease we've studied that could be red and white, like lichen planus? No. So it can't be clinically characterized as any other disease. So clinically, speckled leukoplakia works really well. So, pass the mic. You get off easy. You just have to say the clinical pattern. What is one thing that should be on your differential diagnosis for a lesion that clinically presents as a speckled leukoplakia? Epithelial dysplasia. That's best for the white part. Pass the mic. What's another thing that should be on your differential diagnosis? The second one is always the hardest.
Carcinoma in situ.
Absolutely. Which part of this is most likely to be the carcinoma in situ? The red part. And so this part where it's white patch is probably dysplastic, and this red part is probably the carcinoma in situ. Surgeons get really excited about red things because they worry about the carcinoma in situ. They're going to biopsy that red part. They should do 2 biopsies. This was biopsied, it was carcinoma in situ, so we go to the patient. On the right, totally different story. Does that look like a speckled leukoplakia? It's red and white. No, it doesn't really look like a red and white lesion. What clinical pattern of lesion is it? Everybody.
Ulceration.
It's an ulcer. It's an ulcer. So the story on this patient is that she gets recurring ulcers in her mouth, and they're big, and they're deep, and they hurt, and they're just barely going away when she's already getting new ones. So what do you think this is?
Recurrent aphthostomatitis major.
Absolutely. Recurrent aphthostomatitis major. Do you see the red halo?
Yes.
Yes. We can pass mine. Does anything else have a red halo?
Yes.
Recurrent intraoral herpes also gets a red halo, but it starts with a blister. Aphthostomatitis never starts with a blister, and they occur in different locations, so you should always be able to tell them apart. Recurrent aphthostomatitis major always requires medical management, prescription medication. You should know the name of an appropriate prescription medication to treat recurrent aphthostomatitis major. I am highly likely to ask you that on your final exam.
That's not the major when we have 2 or 3 and we have.
They often have multiple at a time, but I didn't have room for multiple pictures. All right, who has the mic? Patient on the left. A familiar story. Patient had their teeth cleaned. The next day it started to hurt. really, really hurt. He can't really see in his mouth up there very well, but it still hurts, and it's been about 4 days. Goes back to the dentist and says, why does this hurt so much? What's our best diagnosis?
Recurrent intraoral herpes.
Recurrent intraoral herpes. Is that small enough to cover with a quarter? Close, but maybe not quite. But the coin test is a good one. We tend to have recurrent intraoral herpes on gingiva and hard palate mucosa bound to bone, and it's usually small. Clusters of blisters that rupture, coalesce, but it's usually a small zone that you can't cover with a quarter. So that's recurrent intraoral herpes. The patient on the right, see the difference in size scale? So this is a patient who has been ill recently, has developed a chronic medical illness and is medically compromised, older adult. And a couple of days ago, he developed severe oral pain, all just on one side. And about the same time, he developed pain on his face and some swelling and redness. And then he developed blisters on his face on that side, and then blisters in his mouth. And he said, I can't stand this any longer. And it hurt more in his mouth than on his skin, so he went to the dentist. So who's got the mic? What's the best diagnosis for this?
Shingles.
Shingles. So we usually use the term shingles for the skin. So for the face part, shingles is perfect. What's a better term for the mouth part? Yes, herpes zoster. And that's just convention, tradition, but that's usually what we do. But when you see them side by side, you can see that herpes zoster is always more extensive than recurrent intraoral herpes. And yes, it's unilateral. Both of them are unilateral, but this one goes to midline and just sharply stops at midline. And extensive blisters. They're getting a little exudate in them at this point. And but very, very painful. Very painful. Whoa, fun stuff. Who's got the mic? Patient on the left. What do you think the diagnosis is? What's the proper term? Torus palatinus or palatal torus. All right, you're correct. You also get the one on the other side. Does it look like a torus? No, it doesn't look like a torus. So how is the one on the right different than the torus? Can we see induration? Never. Induration is something that you feel, firm and fixed. So what is difference about the appearance of this compared to the torus? There's one thing that you should notice right off. The big red spot? I think there's something more obvious than that.
It's only one side?
It's only one side. It is not centered on midline. If it's not centered on palatal midline, it cannot be a torus. So if you look at the center of this, the center, oh come on, there's my pointer. Oh. Thank you. Pointer's not supposed to do that. It's centered halfway between midline and the gingival margins, where we have lots of salivary gland tissue. So a mass in that location should be considered to be of salivary gland origin until proven otherwise by a biopsy. So if it looks benign, best diagnosis is, what is the most common benign salivary gland tumor? Anybody remember? Pleomorphic adenoma. If it's malignant, if it shows signs of malignancy, what's the most common malignant salivary gland tumor? It's mucoepidermoid carcinoma. So the question we have to ask ourselves now is it benign or malignant? So what are our signs of malignancy? What would be one sign of malignancy we would look for a salivary gland tumor?
We look for...
No, you don't have the mic. I'll ask you when the person with mic has the floor.
Ulceration.
Ulceration. Persistent ulceration. Okay. Now it's open to the floor. Anything else that we look for? Loose teeth, maybe, if it's invading bone underneath. What else?
Can that be the color?
Prominent blood vessels, the color. If we see really prominent vascularity, that's another sign that we see. So the persistent surface ulceration and the prominent vascularity are usually the most common signs of malignancy for our salivary gland tumors. Does this salivary gland tumor show any signs of malignancy? Do you see an ulcer? I see a huge ulcer. I would definitely be worried about malignancy. This is not one that I would show on an exam and expect you to give me the best diagnosis, but I might ask you if there are signs of malignancy, and there are. So this one actually ended up being a pleomorphic adenoma, and it had been traumatized because it was so big. And that's why it had the ulcer. But I would be very concerned about malignancy because of that ulceration. So if I showed you a salivary gland tumor in the palate, and I asked for two possibilities, and you tell me pleomorphic adenoma and mucoepidermoid carcinoma, am I going to be happy with your differential? Not even. Why? Because you're sitting on the fence and you're giving me one benign answer and one malignant answer because you haven't made a decision if it shows signs of malignancy or signs of being benign. So the first decision, if you think the patient has a salivary gland tumor, you have to decide up front if it's benign or malignant. If you think it's benign, you have to give me differentials that fit with benign. Both of them. Or three of them. Probably only asked two. If you think it's malignant, you have to give me two malignancies. If you give me one malignancy and one benign thing, you're sitting on the fence and you're covering your booty and not doing your job, and you get 0 credit. I won't even give you partial credit. So you never combine your benign and your malignant for your neoplasms. You decide it's benign or malignant and go with it. Does that make sense? Mm-hmm. All right. But I won't show you that one unless I'm just asking what kind of malignancy does this have, because that's a hard one. Moving on to the tongue. Who has it? Yes.
So the adenoma and the mucoepidermoid there's always going to be a one side.
Yeah, they're never at midline. They're never at midline. Tori are at midline in the palate, and they aren't. Okay, who has the mic now? All right, you get the easy one. Patient on the left needs no story. What is the diagnosis?
Fissure tongue.
Fissure tongue. I'm going to make you keep the mic. I'm going to make it harder for you. What treatment do we provide for fissured tongue?
Brush your tongue.
Brush your tongue. Does that cure it?
There is no treatment.
There is no treatment, but if you brush your tongue, it prevents secondary infection and stuff because it does tend to trap nasty stuff. All right, pass the mic. What does the patient on the right have? Geographic tongue. What do we call it when it's at some other location in the mouth, not on the tongue? I don't know where Dr. Granda gets that. I've never heard anybody use the term ectopic geographic tongue. Preferred term is erythema migrans. Erythema migrans. Why did I show these two pictures together? Because we often see them in the same patient. So I could show you a case on the final exam that has both of them, and I expect you to find both diseases. Do you think you could do that?
I don't know.
Sure you could, because they're both easy. Now, I have one last question or comment on geographic tongue. What is the most characteristic aspect clinically of geographic tongue? Is it the red bald part? No, it's the raised white little thin edge to it. That's the telltale sign, is that little thin raised edge. It's creamy, kind of creamy tan and irregular outline, sometimes described as a thin serpiginous line. Looks like a snake.
That line is fine.
Going around. So I always look for that. All right, who's got the mic? All right. Patient on the left has been on antibiotics for a respiratory infection, then developed soreness in the mouth. She has this on her tongue and similar findings elsewhere in the mouth, and some of that wipes off and leaves little red bleeding points. What is the best diagnosis? This is a mirror image of median rhomboid glossitis. Median rhomboid glossitis is red in the middle and white at the edge, where we still have taste buds. But you're on the right track. If it's not median rhomboid glossitis, but it's the same underlying cause, what is it? Yeah, it's just ordinary candidiasis. Ordinary candidiasis. So this one's white in the middle and red on the outside, so it's just an ordinary oral candidiasis. Question?
For the oral candidiasis, do we need to know all the subcategories?
You need to recognize the pseudomembranous type. This is a classic pseudomembranous type. That's the one we see the most, but you don't have to put the name pseudomembranous in the diagnosis. We just call that oral candidiasis. There are only three patterns, where we use a different name. They are angular chylitis, which sometimes also has a bacteria in it, but it's predominantly fungal. And medium rhomboid glossitis, which is the bald spot in the posterior tongue midline, that can have white filiform papillae at the edge, but it's a bald spot, red in the middle. And the other one is very uncommon. I don't know if Dr. Thompson talked about it at all, and that's chronic hyperplastic candidiasis. I will not test that. That's an extremely difficult diagnosis and is not even usually recognized as candidiasis. Usually gets biopsy. So I just take that one off the playing table for your final exam. Okay? So the three things that you should be able to use as diagnostic terms, as diagnoses related to Candida albicans infections are oral candidiasis, angular chylitis, and medium rhomboid glossitis. Those are the three you're responsible for using appropriately. All right, pass the mic. Who's got the mic? What is one medication that can be used to treat oral candidiasis? Say it. Nystatin. Very good. Not my favorite, because patients swallow it too fast and it doesn't work. I like clotrimazole better, but Nystatin is probably the classic example of an antifungal medication for candidiasis. All right, Andrea. Patient on the right. Eileen. Why did I say Andrea? It starts with A. My brain farts here. Eileen, what does the patient on the right have? No. One word was correct. Hairy tongue. Which is more common, hairy tongue or oral hairy leukoplakia? Hairy tongue. Hairy leukoplakia is at the lateral borders of the tongue and clinically is not hairy in appearance. It's corrugated but not hairy. So. What do we do to treat hairy tongue?
Scrape it off. Take a bird that.
Improve the tongue hygiene. Improve the tongue hygiene. I see my clinical world path patients on Thursday mornings. Yesterday was Thursday morning. I had a new patient. She had hairy tongue.
Like that bad?
It was worse than that because it was everywhere on her tongue, but it wasn't stained. It was just normal whitish color. But elongated filiform, no, because the camera over at CDO never works right. Oh, it's so maddening. Otherwise, she would be perfect for the final exam. But in her history, she uses an oxidizing mouthwash, which is commonly associated with hairy tongue. What is the most common oxidizing mouthwash that people use? Hydrogen peroxide. And that's what she's using. So I told her, get rid of the hydrogen peroxide, use your tongue scraper, brush your tongue. I like baking soda to brush the tongue. But this will take a while to go away. It takes a while. Beautiful hairy tongue. Oh! So the patient on the left, how would you describe the clinical appearance of that lesion? Use the mic. Describe it into the mic. No, I'm just asking you to tell me what it looks like. Not a word. There's not a one word for this one. Just tell me what it looks like.
White.
White. It's a white floppy. Do you see sloughing? No. I don't see any peeling. I see some depressions in it. What would we call those? Ulcers? Yeah, ulcers. So it's white. So it's kind of like a white plaque with ulcers. And how would you describe the edges of it?
Why stripe?
That part. No, I didn't ask for a diagnosis. How would you describe the appearance of the white of the edge? Where, oh, come on. It doesn't come in here. It's slim. How would you describe it? You sitting too far back? Can't see? People sitting up front, how would you describe the edge? Striated. Notice it's lacy at the edges or plaque-like in the middle, and it's got some ulceration. Do we know of anything that can do that?
Erosive lichen planus.
Erosive lichen planus can do that. So on the tongue, it can be more plaque-like. That's a hard one. But you have to describe it first before you can diagnose it. That's the mic. That was biopsied, and they found mild epithelial dysplasia. Is that a surprise in a patient with erosive lichen planus?
No.
No, because it can be a premalignant disorder. Okay.
All right, so
How would you describe
for that one, crater.
Crater. So what's a professional term for a crater?
That's very, that's a good one.
You can tell me what it is.
Traumatic ulcer.
Traumatic ulcer, so the crater is an ulcer. Yeah, you knew that, exactly. You're trying to make it too hard for yourself. So, a traumatic ulcer typically has what kind of a history? History of biting trauma, if they remember that they did it. Sometimes they do. What about pain?
Yeah.
Hurts a lot at first, and then after a day it usually stops hurting. And what is the typical duration? A few days up to 2 weeks, depending on the size of it, if there's just one traumatic incident. So when do they become chronic traumatic ulcers? When there's chronic trauma and there's repeated biting trauma. Okay. Does this look like a chronic traumatic ulcer?
Yes.
No, it looks like an ordinary simple traumatic ulcer. It should heal in a week. So if it's still there in 2 weeks, what should we be concerned about? Chronic trauma. If there's no chronic trauma, what should we be concerned about? Malignancy. Could be malignancy. But if they have a history of biting their tongue, I wouldn't be so concerned about malignancy. It'll heal. But we don't go longer than 2 weeks without expecting a simple traumatic ulcer to heal. All right, who's got the mic? We move on. Yes. So how would you describe this lesion on the tongue, on the left?
It's white.
It looks white. So is it a nodule or a patch or a patch? It's a patch. It's a white patch. So when we see a white patch, what's the first thing that we want to look around for? We want to look around for any source of mechanical irritation. Yeah.
Yeah.
Do you see anything in this patient that might be causing some mechanical irritation? This part of the tongue, what do you see? We have a crown, and it is a cheap stainless steel crown that has a sharp edge, and it's rubbing the tongue. So what does that make the diagnosis? If it's a sharp crown that's rubbing the tongue that's producing that white patch, what is the diagnosis for the white patch? I've heard it already. Frictional keratosis. Good. Ask the mic. What is the treatment of choice for frictional keratosis?
Get rid of the...
You eliminate the source of irritation. So you fix that tooth so it doesn't bother the tongue, and then you watch it heal. If it's been rubbing for a long time, it might take a little bit longer than 2 weeks to heal, but not much. So that's a nice frictional keratosis. It was biopsied because nobody was paying attention to the crown, and it came back benign keratosis. Can the pathologist see the chronic mechanical irritation in the mouth?
Yes.
No, they can't. They don't know what's going on in the mouth, so they just see hyperkeratosis. They don't know if it's frictional or not. So they just call it benign keratosis. But I will not take benign keratosis as a correct answer if there is a source of mechanical irritation in your body. You have to call it frictional keratosis. Question?
For the one that we just did, I was wanting to guess lichenoid contact stomatitis.
Do you see a white lacy? No, it's a solid plaque and it's maybe a little corrugated. So you would only use the lichenoid contact stomatitis if there's an adjacent restoration where there's not mechanical irritation and therefore it has to be an immune response. So I'm glad we talked about that because that is the other thing you have to think about. Absolutely. Who's got the mic?
Okay.
All right. What do we see on the tongue, on the patient, on the right? What's your diagnosis?
Okay, so I see something on the left. Sure. It's on the.
Right at the.
It's on the border.
It's on the border. So what's your diagnosis for it? Oh yes. Yes, people are seeing it now. Oh yes. Look, the lights go on. There's a clue if you look at the top of the tongue too.
Like that's good.
Yes, so you've got a hint on the top of the tongue. What is the lesion on the side of the tongue?
Geographic time?
Yes! It's geographic tongue. You see the little raised creamy tan edge? That's the good giveaway. Yeah. I actually see it on lab and that's probably more than so yeah, that is geographic tongue in a patient who has a little bit of fisher tongue as well. Okay.
Fisher tongue out.
Oh, you get lucky. What is this? Oh gosh.
Irritation fibroma?
No. Anybody else know what it is?
No.
I get asked for pap consults all the time for this.
Oh.
It's a folia papilla. It's normal anatomy. It's normal anatomy. So we would be concerned about it being pathologic if it doesn't match the size and the shape of the one on the other side. But this is a totally normal folia papilla. Yeah. So don't tell me that's a fibroma. Do you know of anything that you can get, any pathologic lesion that you can get at the site of the folia papilla? There should be one thing you learn.
Something with the lip.
Oral lymphoepithelial cyst. So the crypts in that tonsillar tissue can become occluded in the cyst. All right. So next question. Patient, pass the mic. Patient on the right. Is this a normal folia papilla?
No.
No way. No way. Okay. So what could present as a large, continuing to enlarge mass on the posterior lateral tongue? What do you want to put on your differential diagnosis for that? Absolutely. Good job. That was a squamous cell carcinoma. That was a patient we saw in residency at County Hospital in Los Angeles when I was there. And the patient came in for some other problem, and during his advent physical, he was a homeless street person. They found this mass on his tongue. It was huge.
It's your germs.
That's okay. It was about the size of a golf ball. They removed it and he said, "Oh, I can talk so much better now." It's like, but you didn't know it was there? Seriously? But it wasn't squamous cell carcinoma. It was.
Dr. Richards, the bully one?
Yes.
I was nervous when the first time seeing it.
That's because you're not seeing enough patients yet. But when you see your patients, you want to pull that tongue forward. You're going to look all the way back. And it's a little lumpy area on the posterior ventrolateral tongue. Both sides. It's just tonsil tissue. It's a normal structure. Some people it's a little more flat. Some people it's more raised. That's pretty good normal. Patient on the left. This is my patient from middle school. This mass had been on her tongue for many years. She bites it sometimes and it hurts for a few days. But other than that, it doesn't give her any trouble. And it's pretty much been the same size for years and years. What's the most likely diagnosis? Irritation fibroma, yes. So I got to excise that as my biopsy case as a dental student. When I came back to teach, I found the photo in the department slides, because we use real square projectable slides, and it said student copy, and I had been a student, so I kept it. It's mine now. It's my patient. Beautiful irritation fibroma. Where do we most commonly see irritation fibromas?
On the cheek. Buccal mucosa.
Buccal mucosa, occlusal plane, lower lip, just inside the wet dry line, and lateral border of the tongue, all of the places where you can bite. You bite the edge of your tongue, you bite the edge of your cheek and lip. What about the upper lip? Almost never. It's hard to bite your upper lip. You have to work at that. It's usually lower lip near the commissure. Occlusal plane on the buccal mucosa or lateral border of the tongue. All right, past mine, and you have it. All right. So the patient on the right is a child. You can see primary teeth, stainless steel crowns. This is a kid, about 4 years old. This child has a mass on the tongue. He doesn't remember biting his tongue. Mom has been watching this for about 6 months and says this has gradually and steadily enlarged for 6 months. Is this an irritation fibroma? No. No. That doesn't fit with the history. A gradual steady enlargement. So gradual steady enlargement fits with a neoplasm, exactly. So my question is, Sarah, what is one example of a neoplasm that we might see on the tongue? Pardon?
Carcinoma, but
a carcinoma, would it gradually enlarge? And do we see carcinomas very frequently in young children? No. So everything about this says it's benign. It's well defined, fairly round, gradually enlarging. It sits with benign neoplasm. So what's one benign neoplasm that we might see on the tongue? Don't know? I need to hand me back that mic. It's going to come back to the front. Actually, I don't think we'll pass the mic anymore because we want to get through the rest of these.
Great idea.
So, my question is, anybody? A neurofibroma. So, the most common benign neoplasms on the tongue are of neural origin. This could be a neurofibroma. What is another benign neural tumor that we could see on the tongue? A granular cell tumor. Which of those particularly likes the tongue? Granular cell tumor. This happens to be a granular cell tumor. But I would, on a differential, accept any of the benign nerve tumors. We don't get very many non-neural benign neoplasms on the tongue. Most of our tongue neoplasms that are benign are neural in origin. Okay, we have already seen the patient on the left because it was on our last exam.
Yeah.
And it had been enlarging for months. We know at least 9 months, but we're pretty sure the patient was aware of it longer than that. And what's the best diagnosis for that one?
Squamous
cell carcinoma. Do you all see a mass?
Yes.
Good. And notice how it has an irregular surface, and it's part red, it's part white. That fits really, really well with squamous cell carcinoma. That's what it was. The patient on the right has a tongue lesion that's also red and white. Is it a squamous cell carcinoma? No. No, why? There's no mass. So it's really important when we see lesions to think about, is there a mass or no mass? Is this a flat patch kind of a lesion where there's no mass? Or is this something that has bulk and thickness and an elevated edge? Because we have a different diagnosis. So the patient on the right is an older adult male. He's a heavy smoker drinker. Painless lesion, solitary lesion, ventral tongue. What do we want to put on our differential diagnosis for that?
What kind of smoker?
What kind of smoker?
Like pipe or?
He smokes cigarettes. If he was a pipe smoker, would you call this nicotine stomatitis?
No.
Never. That applies exclusively to the hard palate mucosa. So, what do we want to put on our differential diagnosis? Carcinoma in situ epithelial dysplasia, just like any other red and white erythroleukoplakia, speckled leukoplakia lesion. Sure. What if this was a pipe smoker? Would that change our differential?
No.
No. So, would we see this lesion in a patient who used smokeless tobacco? No, we wouldn't, because it's the wrong location. That's not where they put their chew. They don't put it under their tongue, they put it in the vestibule. So, doesn't fit with a smokeless tobacco keratosis. Wrong location. And that was biopsied and it ended up being moderate epithelial dysplasia. So it's well into the process of being premalignant. Is epithelial dysplasia potentially malignant disorder?
Yes.
Absolutely. It's already premalignant. It could become malignant at any time or maybe never. And we can't predict, and that drives us nuts. Okay. Everybody, what pathology do you see here? What? Sublingual varices. Those are super, super, super common. You should be able to instantly recognize them. How do we treat them? No treatment is indicated for this condition. I love students, they always put none. I don't like none on a workup. None often means I didn't think about it. So I always like to put no treatment is indicated for this condition. Then they know you thought about it, and that's all you need. Nothing. All right, we move on to the floor of the mouth. We're almost done. This is a normal floor of the mouth, as normal as I could find, but there's actually a little bit of pathology. What do you see? Little baby mandibular tori. Yeah, little baby mandibular tori. Okay. So what do we see in the patient in the left? Teenage mandibular tori. Lovely teenage mandibular tori. So those are mandibular tori. And what do we see on the patient on the right?
Ankylosing.
Ankylosing and baby mandibular tori. But what's the predominant thing that you can't miss? The ankylosing. How do we treat ankylosing? Frenectomy or frenotomy, either one. We don't actually excise the frenum, we just do surgical revision to release the tongue. All right. Patient on the left says my dentures don't fit anymore. They don't seat down. I'd like new dentures. Does that look like epulus fissuratum? No. It goes over the ridge and into the floor of the mouth and onto the ventral tongue. It's red and white. Do you want to know anything else about this patient?
Does he smoke?
Does he smoke? Absolutely. He's in his 70s and he's been smoking since he was a teenager. Yeah. So what else? You want to know anything else about him? He doesn't like to go to the dentist. He hasn't had an oral exam in years. Okay, so what's our best diagnosis? That's a beautiful squamous cell carcinoma. If you tell me anything other than squamous cell carcinoma for a lesion like this in this location, no credit. Please recognize a blatant squamous cell carcinoma. Patient on the right, also a smoker, been a heavy smoker for years. See a little tobacco staining on the teeth, just a little bit. Regularly sees the dentist, comes in, well, maybe not every 6 months, but at least once a year for an exam. And this lesion was an incidental finding on examination this year, but wasn't there last year. And it's painless and patient was unaware of it. We do not know its duration, except we know it's less than a year old. So, what would we put on our differential diagnosis for this lesion?
Epithelial dysplasia.
Do you think this could be epithelial dysplasia? Do you think this could be benign keratosis?
Oh, wait.
Do you think this could be frictional keratosis? No, not a good place for that. Anybody think this looks like lichen planus?
No.
No, good.
We have white and red.
Would you biopsy this?
Yeah. I don't think it is.
Or the red, yeah.
If you don't know what it is, and you can't find any local factors, then you could biopsy it now, or you could wait 2 weeks and see if it's still there and then biopsy it. But if you can't find any local factor that you can change, what's the one local factor you could change? The smoking.
Yeah.
So for just a patch kind of lesion, you could have the patient stop smoking for 2 weeks, come back, reevaluate. And then if it's still there, then you could do your biopsy. Do you see a mass effect?
Yes.
No.
No?
That's the shape of the normal anatomy. That's where Word's papilla is. That's the caruncles or the lingual papilla, whatever you want to call it. So there's actually not a mass effect. So your differential diagnosis should be hyperkeratosis or epithelial dysplasia, because this is just a red and white patch. It did persist. It was biopsied. It was severe epithelial dysplasia, almost carcinoma in situ. But it just looks so innocuous. But that's potentially deadly. So standard of care for treatment for severe epithelial dysplasia is removal of all remaining clinically abnormal tissue, which means all around the edge and all around this edge. Is that an easy surgery? No, because the duct comes out there, so they're going to have to move the ducts and make new. That's reconstruct. That is not an easy surgery, but it has to be done, or the patient could progress to invasive squamous cell carcinoma and die. We don't want the patient to die. All right. What is this? Linea alba. How do you know it's not morsicaceous bacarum?
It's not this, it's like a
Because
line.
it's smooth. It's smooth. It's not rough and ragged. All right. This patient on the right, morsicaceous bacarum. No. What do you see? Sloughing. So that fits best with chemical burn. So that patient that I saw yesterday with a hairy tongue also had this kind of thing on the cheeks going on. So definitely got to get rid of that hydrogen peroxide that she's using as a mouthwash, because it's burning the tissue and producing hairy tongue. So that's a chemical burn, probably from mouthwash. Actually, this patient, it was mouthwash, because I know the story on this patient. Cheap store brand mouthwash, too strong. Oh, innies and outies. So this is an outie, been there for years, no longer enlarging, painless. He bites it every now and then. Recently bit it. They're two tiny little petechia where he recently bit it. But other than that, doesn't bother him. What's the best diagnosis? Irritation fibroma. So, patient on the right has a different story. Patient at the right was in the dental office yesterday for a lot of restorative work. They did a long buccal nerve block, and patient left the dental office and went out to eat for lunch and was very hungry and still very numb and disappeared.
Traumatic ulcer.
So what is it?
Traumatic ulcer.
A lovely traumatic ulcer. Yes. That's why we tell people, you're numb, but be careful, don't bite it. All right, these are both outies. What color are they? They're dark what? They're dark red, blue, purple. They're in that red, blue, purple range. Red, blue, purple always goes with what as a source of the color? Blood. Okay. So they have different stories. The patient on the left is an older adult who has had this lesion for many, many years. It has not changed in size. Doesn't give him any trouble, but it's there. And if you apply pressure, it blanches. So what's the best diagnosis? Venous malformation. Us old pathologists prefer to call them hemangiomas, but they've changed how they apply those terms. It drives me nuts. But that's a nice venous malformation. Venous malformation. It has flowing blood in it, and that's why it blanches. Question?
Can we say vascular malformation?
Vascular malformation is not specific enough. So the most common ones are venous malformations. If you're working with an arteriovenous malformation, you will get information like you can feel a pulse in it or hear the brewing in it. And those are not very common, not very common at all.
What's the difference?
So the difference?
Between those two, between venous malformation and hemangioma.
Venous malformations are a malformation from a young age, but it persists throughout life. It doesn't regress in size. Hemangiomas are kind of the same. They're like venous malformations, but they can increase in size during those growth and development years. Sometimes they completely go away. They often completely go away. Less frequently, they persist for life. In all honesty, it is very difficult to apply the new, very arbitrary diagnostic rules that they have. And venous malformation and hemangioma often can't be distinguished. You often don't have adequate history, and they're the same histologically. And they've created some arbitrary rules that are very difficult to apply. So we will try to give you cases that follow the rules, because we get to build to the cases and add information. So know the rules for how you apply those terms, because Dr. Grandi will give you something that follows the rules that she's given you, so you can tell them apart. But they're very frustrating. And the people who change the rules are the ones who only see the biopsy specimens and never see the patients. It's like, you are not the people who should be changing the rules. That doesn't even make sense. So the patient on the right has a very different story. This is a patient who had no lesion when he came into the dental office this morning, but when he left 2 hours later, at the end of a long appointment, this was present. It does not blanch. It's a hematoma. It's a hematoma. Guess how it got there? The high volume suction was left on the mucosa. It was a special type of sphincter thing that holds the tongue away and all this bed, and it slipped and was sucking on the tongue for 2 hours. Yeah, exactly. That's what we call iatrogenic. Yes. Anyway, but that's a hematoma. They don't blanch because the blood is clotted. It's not flowing blood. It's a hemorrhage and the blood clots, and so they don't blanch. Whew. Similar but different. Patient on the left is an adolescent. She has no complaints. When we look at her mouth, she has similar changes on both sides as well as the lower lip. What is the best diagnosis for this?
Morsicaceous
baccarum for the cheeks. What about the lip part? What do we call that? Morsicaceous labiorum for lips, yes. And we're looking at the cheek mostly there, so that's morsicaceous baccarum. Will that scrape off? No. But it often has a ragged surface because the patient is chewing on it and kind of biting chunks of it off. The patient on the right, came into USC when I was resident. So I spent 2.5 years at the hospital and 6 months at the dental school. But this was one of our dental school patients, and he came in on a Monday morning for urgent care treatment of a horrible toothache he had had all weekend, terrible pain, and the story was, started out with a horrible toothache, but now my cheek hurts too. So what's the best diagnosis for the cheek lesion?
Aspirin burn?
Aspirin burn. So he decided that the aspirin would help his toothache more if he just put it right there next to the tooth, and he burned the living daylights. And you see where it's kind of cracked and is peeled off? It's dead tissue. It's superficial coagulative necrosis, and it can slough off and peel off, but this was a fairly deep burn and it did hurt. Aspirin burn. So we tell our patients that aspirin works better if you swallow it. Yes, please swallow it. Okay. No history. What does the patient on the left have?
Reticular
Reticular lichen planus, reticular lichen planus. Striae, always think reticular lichen planus. Yep. Does the patient on the right have reticular lichen planus? No. That is correct. So what does it fit with? Morsicacia vicarum again. Yes. They look different. Vestibules. So the patient on the left has been getting mouth sores for almost a year. He notices sometimes they start with a blister, but the blisters don't last very long. They pop. It kind of hurts, but it's not horrible. He had mouth sores first, but now he's getting blisters on his skin as well. So what's the best diagnosis? Pemphigus vulgaris. So what's the other blistering oral disease? The other blistering oral disease, that's a chronic blistering oral disease, is mucous membrane pemphigoid. Do they get skin blisters? No, it affects mucous membranes. So if you know their skin involvement, it's pemphigus vulgaris. Pemphigus vulgaris usually has more shallow and less painful ulcers and erosive lesions after the blisters pop. So the patient on the right has a different story. This patient has very, very painful mouth lesions, and they have been present for only about 4 days. And is that erythema multiforme? Yes, it is. Does erythema multiforme start with blisters?
No.
Not usually, no. It just goes straight to oral ulcers, and often you do not get a good intraoral picture because they have so much ulceration they can't open enough to take a picture. It's extremely painful. How would you describe the changes on the vermilion border and wet dry line? It's kind of crusting, so the ulcerations crust. And if they do open wide, it tends to crack and bleed. So a classic description is that bloody, crusty lips. So this one has more crust and less blood, but very extensive ulceration. And the inside part is whitish because the ulcer membrane is very wet. So it looks like all that whitish stuff is ulcer membrane. But very extensive, very painful oral ulcerations. Erythema multiforme. The ordinary kind. Oh. These are both older women. They both wear dentures. They both say their dentures don't fit into place anymore. Do they have the same disease? No. No. What does the patient on the right have? They're right. We're starting on the right. Ordinary ebulus fissuratum. And we just excise that and make new dentures that fit. Yes. Does the patient on the left have epulus fissuratum? No. No, it's the wrong color. So do you need more history? Yeah. Yeah, the patient uses snuff. Has been placing snuff there for years. So what should you be concerned about? Is this smokeless tobacco keratosis? No, because it has thickness. There's mass effects. Smokeless tobacco keratosis is a patch pattern lesion, flat. No mass. So what is the mass that we get associated particularly with chronic snuff use? Verrucous carcinoma. What's special and important about verrucous carcinoma other than its association with snuff?
It's pretty safe.
It's pretty safe. It's a cancer.
It's not metastatic.
It almost never metastasizes, therefore it can be cured by local excision. You might need to take a fairly wide excision, but the patient's going to live. Does that mean you can ignore it and not treat it?
No.
No, you need to treat it as soon as you find it, but the patient's going to live. That's a familiar one too. The one on the left, that's our smokeless tobacco keratosis. See how it's flat? It's a patch. So it's often got some surface changes in color, sometimes some wrinkling and folding. There's a little wrinkling there, but that's a nice typical smokeless tobacco keratosis. Does the patient on the right have smokeless tobacco keratosis? No. No. What pattern lesion do we see there?
Striae.
Striae. What do we think of when we see striae?
Lichen
planus.
planus.
And this one's a little red in the middle, so yeah, that fits with erosive lichen planus. If it's just reticular pattern, you can just call it lichen planus. But if there are red areas or areas of ulceration, it's really important to add the erosive to the diagnostic term because of two things. Once you get to the erosive stage of lichen planus, it always requires medical treatment. You always have to use medications, and it has an increased risk for malignancy. And it's an important association to make. So always call it erosive lichen planus if it is erosive.
Is it always safer just to put lichen planus, or since this one is by a restoration, would it be the lichenoid?
Could this be a lichenoid contact stomatitis? Possibly. I think it's important to know more information. If this is bilateral and symmetric and they're all over the cheeks as well, I'd go with lichen planus. Lichen planus is much more common than lichenoid contact stomatitis. Was that the same question we had over here? Good questions. Good questions. Have a little bit on the lips. There it is. That's our lichenoid contact stomatitis. And it's contacting an amalgam.
Yep.
And that's the one we see most commonly is amalgam reaction, more so than cast metals. And we see the red contact stomatitis with the cast metals. And, I don't even need to tell you what this one is. A small, blanching purple spot.
Venous malformation.
Venous malformation. I think I have hemangioma on that, but it's a venous malformation. Is this a venous malformation?
No.
No. That's a squamous cell carcinoma. Yep, lower lip. And see how it's growing past the skin border, past the edge of the vermilion border? Oh, what's the one on the right? The one on the left. Rapid lip swelling. Angioedema. And it's nice and soft. It'll be gone in a day or two. Does the patient on the right have angioedema? No. Patient on the right complains of a dark spot on the lip that's gotten larger over the last year. Do you see a dark spot?
Yes.
Well, gee, he's kind of freckled. But do you see some asymmetry in the pigmentation?
Yes.
Yes. So what's your diagnosis?
Melanoma.
Is this malignant melanoma or is it labial melanotic macule?
Labial
He says this is getting larger over the last year and spreading. Does that fit with a labial melanotic macule? No. It's a melanoma.
Oh man.
This was actually a dental student. And yeah, he was way too young for it, but he was very fair complected. And it was diagnosed when he was in dental school, and they excised about a third of his lip, and he had very good cosmetic results and is still alive. So that was good. Whew. Persistent little crusty things. Patient thinks his lips are chapped. 2 different patients. What do we call this? As a clinical diagnosis.
That's the clinical diagnosis.
Clinical diagnosis is actinic cheilitis, and when we biopsy it, which we better do, we'll find out if it's totally benign or has dysplasia or is even worse than that. These were both biopsied, and the one on the left was severe epithelial dysplasia. Does it look like a severe advanced lesion? Not at all. That's why we have to biopsy them, because you cannot tell clinically what's going on in the tissue. And the one on the right was actually early invasive squamous cell carcinoma. So it was already malignant. Ooh. So the patient on the left was a patient we saw when I was resident. Presented to the dentist with a round, like marble, firm marble-like thing under the surface that was movable. You could move it around a little bit. And he said it had been there for a couple of years, and it was gradually getting bigger the whole time. So what type of disease process does that fit with? A movable submucosal nodule that's steadily, gradually increasing in size. Sits, it doesn't fit with a cyst or a benign neoplasm.
Benign neoplasm.
Benign neoplasm. It's better with a benign neoplasm. What if we said it was fluctuant?
Then
And it could be a cyst, but this is a very uncommon place to have a cyst. But this was firm, not fluctuant. It was a solid nodule. So what is a benign neoplasm that could be in the lower lip? Could this be salivary in origin?
Yes.
Sure. So it could be pleomorphic adenoma, sure. Do we have other tissue that could give rise to a benign neoplasm in the lower lip? Well, sure, we have connective tissues. So it could be connective tissue origin as well. If it's upper lip, it's more likely to be salivary. If it's lower lip, it's actually more likely to be connective tissue origin. I'm not sure that I would expect you to know that. Anything that's a benign neoplasm where there's tissue of that type in the area would work for me. This was biopsied, it was removed, and it was actually schwannoma. It was a benign nerve tumor. Yeah. So, patient on the left is an older adult who has a movable nodule in the upper lip that has been slowly enlarging for about 2 years. So I just gave you a rule to follow. So, could it be pleomorphic adenoma? Maybe. What's the most common benign salivary gland tumor we see in the upper lip? There's one that loves the upper lip. Canalicular adenoma. And that's older adults too, so the age also fits. And, ooh.
Nug. Traumatic ulcer.
Nug?
Oh, I was looking
It's
at
a
the
lip
teeth,
ulcer.
sorry.
No, just nasty, crusty teeth. But the
Nasty crusty
so we have to worry about is this traumatic ulcer associated with chronic trauma? That's been there 1.5 years.
No, it's not.
Yeah.
Depends on
Or is it a neoplasm? So you got to look around. You always have to look for your source of trauma. And he lost a crown, and he's been biting on it. So it's more likely to be a chronic traumatic ulcer. And you know some other diagnostic terms for chronic traumatic ulcers. But we still always worry about it being a malignancy. But the first thing is to protect it from further trauma. Put a temporary crown on that and then reevaluate how fast, how soon?
2 weeks.
2 weeks. I would not reevaluate sooner because that's been there 1.5 years and it needs time to heal. So what if it's way, 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 way better but not completely gone in 2 weeks?
Then you would biopsy it.
Then I'd give it another week because it's been there a really long time. But if it's only been there like a few weeks and it's not gone in 2 weeks, then I would biopsy it. But if they've been there a super long time, they take longer to heal. And it ended up being a traumatic ulcer, and they did biopsy it because they were very concerned about that one. I have like 2 extra oral lesions. All right. What region are these swellings in?
Parotid.
Parotid, yeah. These are firm masses. The one on the right is movable. It has slowly enlarged for about 3 years. What is the single most likely diagnosis? The one on the right. Single most likely diagnosis for a movable, slowly enlarging mass in the parotid gland is pleomorphic adenoma, our most common benign salivary gland tumor. Yeah. I know, we're losing focus.
We got this. Come on, keep going.
The patient on the left has a very firm tumor. It is not so movable. There is a little fixation to the underlying structures. And in recent months, he's developed a little facial paralysis. So what are we concerned about for him? Malignancy. Do benign tumors affect nerve function? No. So what's the most likely diagnosis for this one? If we think it's malignant, it is most likely to be mucoepidermoid carcinoma. And if I ask for a differential diagnosis, you could put any of the other malignant salivary gland neoplasms that can occur in parotid. So that one was biopsied, actually ended up being adenoid cystic carcinoma. This one was pleomorphic adenoma. What are those? Yes, needs no history, basal cell carcinomas. And do I have anything else? I'm not sure if I do. Oh, last one. I think this is in one of our textbooks.
Pigmented lesion.
Pigmented lesion for sure. Is this a pattern that we usually see with benign pigmented things?
No.
No. Is it bigger than 6 millimeters?
Yes.
Does it have an irregular outline?
Yes.
Yes. So we should be very concerned about
Malignant.
Malignant melanoma.
malignant melanoma. And it's been getting larger and spreading over time, so it's evolving. So yeah, that's malignant melanoma. And that was the last one I have. So thank you for staying with me for the bitter end. We took too much time and we didn't get to the jaw lesions. But as you think about your jaw lesions, remember you have to make some lists of things. These are the lucencies, these are the mixed lesions, these are the opaque lesions. Pay attention to where they like to live, what their borders are like, ages. So you're going to need several little lists, tables. Those will help you. And you just go through, ask the right questions. Just go through and ask the right questions. I wish you the best for all of your exams next week. All of them.
I know you barely have time, but one of the questions that I wanted to ask you about was, yeah, sorry.
That is a very
question.
Thank you. I got it.
Did you go in and actually look at the scoring comments? But did you look at the scoring comments?